Okay, thank you everyone for attending this Rheum 101 Rheumatology for Non-Clinicians event, which is coming to you today on the 12th of September from the University of Manchester. So first things first, what is UK-RiME? Well, UK-RiME is the UK research in musculoskeletal epidemiology, and it's a national collaboration between 8 epidemiology centres in those places listed on the slide there, and it's supported by Arthritis Research UK. The website is at the bottom of that slide there if you're interested in more details. And what is Rheum 101? Well, Rheum 101 is Rheumatology for Non-Clinicians in Musculoskeletal Research, and this is an idea that came from the UK-RiME statisticians network. In that network, we identified that non-clinician researchers typically have access to lots of training in methodology, but not so much training in rheumatology. So that's what we're here to address. Today we're being hosted by the Arthritis Research UK Centre for Epidemiology at the University of Manchester. We're broadcasting live on YouTube with a link given there, and the recording will be available online after the event as well. We've got 2 topics for you today, the first of which is osteoarthritis with Dr. Jenny Humphreys and rheumatoid arthritis with Professor Kimme Hyrich. We've got 20 minutes talk per topic and then 10 minutes for questions. Obviously, people here in Manchester can ask a question in the traditional way, but those watching remotely have 2 options with which to submit their questions. We won't be doing a Eurovision style going around the different venues. People watching elsewhere can submit questions via Twitter using the hashtag Rheum101 and using the email address rheum101@manchester.ac.uk. Today's event is the first Rheum 101 event that we've run. It's something of a pilot, so we're really interested to hear what you think of it. People here in Manchester hopefully have a paper feedback form in front of them, and for everybody else there's an online survey which I encourage you to fill in, please. And so, without further ado, we'll move to our first speaker, Dr. Jenny Humphreys. Thanks, Jenny.
Thanks, Jamie. Hello everybody and welcome. My name is Jenny Humphreys. I'm a NIHR clinical lecturer and a rheumatology registrar in the region, and I'm going to talk to you about osteoarthritis. So just to give you an overview of the talk, as an epidemiology centre, I'll talk to you a little bit about the epidemiology of osteoarthritis, how these patients present clinically, some information on the investigations that we use, management, and then time for questions at the end. So what is the epidemiology of osteoarthritis? Well, it's the most common joint disease in the world. It affects the vast majority of patients over the age of 65, and that's upwards of 8 million people in the United Kingdom. The prevalence increases with age, so that 80% of people over the age of 75 are affected in some way. And in the recent Global Burden of Disease survey in 2010, hip and knee osteoarthritis combined were the 11th highest contributor to global disability. And they mentioned in the publication that that's likely to be an underestimate because of the methodologies involved. In terms of the economic impact, the negative impact on the UK economy of this disease is about 1% of our gross national product. And there are 2 main types, primary osteoarthritis and secondary osteoarthritis. So how do these patients present when they turn up to a doctor or a healthcare professional? So the typical symptoms are sign, pain in a joint that's related to use, pain that gets worse throughout the day. They do get some stiffness first thing in the morning, but it's usually 20 minutes or less, or in fact, probably more like 5 to 10. And they get what's called gelling after an activity. So after a period of being seated or in one position, they find that their joints just need a little push to get going and decreased range of motion. The joints are unstable, so they can give way, and particularly people talk about knees giving way. You get bony enlargement, that you can see a little bit in some of these pictures here, and you'll see some more of that in a moment. And these are firm swellings as opposed to the sort of swellings that you see in inflammatory arthritis, where they're more sort of soft and squidgy, that Kimme will talk to you a bit more about later. And some restricted movement and crepitus, and that word crepitus there means creaking joints. Although noises in joints don't really correlate with clinical pathological findings, so they're quite hard to interpret in the context of the clinical presentation, but patients will talk about them and you may be able to detect it. And these symptoms wax and wane, so it's a very sort of classic part of the history of OA is that you'll go through periods of time where symptoms are more severe and times when it improves. So just to illustrate that, I'm going to talk to you about a couple of cases. The first case one is a 62-year-old male who'd had knee pain for many years. It was worse descending the stairs, which again is fairly typical for knee osteoarthritis, worse after activity. But actually, recently he had some episodes of swelling of the right knee. His symptoms generally improved with rest, but he was unable to take anti-inflammatories such as ibuprofen because of stomach problems. And again, this is a problem that we see quite commonly in patients with osteoarthritis because irritation of the stomach lining with anti-inflammatories is also common. Just a bit more information about him in terms of his social history. He was a commuter. He'd commute 2 hours each way every day on the train. And he was keen on golf, but couldn't play it very often. Engaged in some gentle dog walking at the weekend. And was a little bit overweight, you know, in the way that 60-odd-year-old men sometimes are. And this isn't actually his knee, but just to show you what a knee swelling could look like. This knee here on the right is obviously more swollen than the one on the left. And that wasn't particularly warm or hot. That was quite sort of cool to touch. And again, that's more typical of an osteoarthritis knee swelling or effusion, as we call them, compared to the type of swelling that you might see in rheumatoid or other inflammatory arthritis. So, who can make a diagnosis of osteoarthritis? Well, actually, any of these people can make a diagnosis of osteoarthritis. This particular patient went along to his GP, but he could have seen an orthopedic surgeon, he could have seen a rheumatologist, he might have seen a physio, and any of them might have been able to confirm the diagnosis. As I say, he saw his GP, who sent him for an X-ray, and again, this is not his X-ray, but this shows the typical features of an X-ray in knee osteoarthritis. So you have the joint space is narrowed, particularly on one side. So you see there's space between the two bones there and less there. These things called marginal osteophytes, these little spiky bony bits here, they're extra bone. You get increased whiteness in the bone. This is called sclerosis. So a normal knee X-ray, you wouldn't see so much whiteness around the joint. And because of the loss of joint space here, this joint is not actually aligned correctly. And these kind of features are going to nail the diagnosis for you. So this is primary osteoarthritis. We talked about the fact that there are two main types of osteoarthritis, primary and secondary osteoarthritis. And I apologize for the skeleton here. This is the one that was free Creative Commons license on a clip art, so he's quite casual there. But these are the typical patients that we see primary OA. You can get exceptions where primary OA affects other joints, but it really should trigger you to think about secondary OA in those instances. So the typical places, the knee we've talked about in this patient, the neck, lower back, hip, and the hand, it's the base of the thumb and the ends of the fingers and the base of the big toe down there. So this is illustrated a bit more by case 2, who's a 75-year-old woman. She's had pain and stiffness in all of these places we've just described, pretty much in knees, hips, thumbs, and occasional back pain. She's got a family history of similar problems in her mother, and when you examine her, she's got bony, hard enlargements of both her knees, restricted, that's range of movement in both of her hips. She's got a squaring of the base of both her thumbs, and I'll show you what that means in a second, and multiple Heberdens and Bouchard's nodes, and again, I'll tell you what those are in the next slide. So So when osteoarthritis affects the hands, it tends to classically affect three main joints. First of all, the distal, the furthest away from the center of your body, and the proximal interphalangeal joints, which means the joints of the fingers. And when you get osteoarthritis on the distal interphalangeal joint, it's called a Heberden's node, this bony swelling here. And when it's the proximal, it's a Bouchard's node. And you can see how the changes are reflected in the x-rays as well. And then we also talked about the base of the thumb and squaring of the base of the thumb. You can't really see it on the picture there, but on this x-ray you can see more clearly this thumb is more of a 90-degree angle. And if you look at your own hand, you should see that it's not really 90 degrees. So this joint at the base of the thumb is called the carpometacarpal joint, and it's the most commonly affected osteoarthritis joint in your hand. This radiograph shows quite severe changes here. Again, you've got that increased whiteness, that sclerosis there, and loss of joint space, compared, say, to this joint here where there's a bit more space. And because it's your thumb's so important in function, this can cause a significant loss of function, cause a lot of problems. This was her hip joint, which was also horrendous, showing, again, these osteophytes. In fact, there's so much sclerosis here, so much extra whiteness, it's kind of hard to see the osteophytes, the extra bony, spiky bits at the margins. And there's no space. There should be a darker space where you can see the difference between the femur, the thigh bone, and the pelvic bone, and you just can't see that there at all. And these patients will often present with pain deep in their groin that goes down into the thigh. And when you try and move their hip around, when you turn it inwards or outwards, they'll complain of worse pain. So, what are the risk factors for primary OA? Well, in the last two cases, we've kind of seen most of them. The key ones are, as I've said a few times now, age, female gender. Females are more predisposed to primary OA. Being overweight and having a family history of osteoarthritis. I put neuromuscular dysfunction down here, but that's probably more of a secondary OA. And essentially that means any disease that causes loss of function of some of the nerves or the muscles around a joint. So that will then cause problems with the joint and make it more prone to osteoarthritis. But realistically, that's probably more of a secondary phenomenon. And this is just to show the age-related prevalence again. So you can see in both men and women that at all of the common sites, so that's that finger joint, the distal interphalangeal joint, the knee and the hip, in both men and women, it increases as you get older. What about secondary osteoarthritis? Well, again, this is essentially osteoarthritis that happens as a result of another disease or another problem. It can be anatomical, so essentially people who are born with some problems with their joints. Some children often have something called talipes as children, which is where one of the feet has got a little bit squashed inside the womb. And if that isn't corrected, that can cause problems with osteoarthritis later on. Also talk about children having congenital dislocation of their hips. And again, if that's not picked up, then they will get abnormal biomechanics, essentially, that can lead to osteoarthritis. So the football is there really to show trauma, and any joint that's been affected by trauma will be more prone to developing osteoarthritis. Neuromuscular dysfunction, as I've said, essentially this is any disease that can cause a problem with the nerve supply, and that's not just nerves supplying muscles, so the muscles are functioning, but also sensory nerve problems, because if you can't feel your joints properly, you may injure them more often, or there may be kind of just slight trauma that's occurring that will lead to abnormalities that can drive osteoarthritis. Metabolic disorders we'll talk about a little bit more. And then inflammatory joint disease, I'm not going to talk much about because Professor Hyrich is going to talk about those in a minute, but they can cause destruction and damage to the joint that can obviously then lead to secondary OA. So an example of both a metabolic and a neuromuscular problem is diabetic neuropathy. So in patients with diabetes, they can get damage to the very small nerves, particularly in the ends of their toes and their fingers. And in your toes, this can lead to that phenomenon where I was saying, if you're not able to feel your toes and your feet properly, you may end up causing some trauma to them just as you go about your day-to-day activity, or even something like wearing shoes that don't fit properly or anything like that and walking on them. You can get these kind of severe changes, and the destructive changes that you see tend to be much greater than those seen in primary osteoarthritis, because you just don't have any of those sensory protective mechanisms. It also affects different joints, so the ankle joint is affected here, and that's not one that we classically see in primary osteoarthritis. So there is a disease called calcium pyrophosphate disease, which is also known as pseudo-gout, where you get deposition of calcium crystals within the joint, and that's seen about 30% of people with OA. And it's also associated with a whole bunch of other metabolic disorders, which are just listed here. They're not sort of critical to know about, but just to give some other examples of metabolic disorders that you see that can cause secondary OA. So what about investigations? What do we typically do to try and investigate osteoarthritis? Well, as I've said, plain X-rays are the mainstay of investigations, and in terms of research, we still quite often the Kellgren-Lawrence grading is the most commonly used outcome for assessing the progression of osteoarthritis in these patients. We do increasingly use MRI scans, and there is some things that you can see on MRI scans that you can't see on plain X-rays, such as bone marrow lesions, which are essentially little bone bruises. You can see the things you'd see on X-rays, like osteophytes and erosions, but you can also see some inflammation with inflamed lining of the joint, which is what synovitis is, and a joint effusion. Plain X-ray findings correlate actually fairly badly with the symptoms that patients experience, but there's evidence to suggest that actually the changes that you see on MRI, such as the bone marrow lesions and synovitis, correlate a little bit better. And one of the problems in research in OA is that radiological findings are the main focus often for outcomes. So there are no good laboratory tests that are helpful. Inflammatory markers are typically normal. If you do have a swelling on a joint, you can get some fluid out of it. You can see some typical findings there, which is more helpful. And this is just to show how the osteoarthritic joint progresses. That's a normal joint here. You can start to see damage coming here with the little spiky osteophytes there. And this is much worse, where you've got the malalignment, loss of joint space, loss of cartilage, and all sorts of problems. I'm just going to try and speed up a little bit. So in terms of management, you break it down to pharmacological and non-pharmacological therapies, and I'm going to go through them one at a time, so I won't pause too long on that. Non-pharmacological therapies are actually really the mainstay of treatment, and there's a strong association with obesity and osteoarthritis. With a BMI of greater than 30, you have a fourfold increased risk of osteoarthritis. You also tend to get disease on both sides. So there's good evidence to suggest from a number of different trials that losing weight helps both pain and function, as well as decreasing your risk of developing osteoarthritis. So weight loss is one important thing to do. Exercise is really crucial. There's a Cochrane review just published just last year showing that exercise reduces pain and improves physical function. Muscle strengthening exercises in particular can be useful, as well as these other physiotherapy interventions. So the reason muscle strengthening is important is because we know that in, for example, knee osteoarthritis, you get loss of strength of your big thigh muscles, the quad muscles here, and that correlates with severity of symptoms in osteoarthritis. And there's been 3, possibly more at this point, randomized controlled trials showing that this improves quadriceps strength, function, and knee pain. You can also do reconditioning exercises. These have the advantage of having, if you go to sort of aquatics, some group support, which helps with some of the psychological aspects. One of the other big problems in osteoarthritis is this idea of changing the biomechanics with the malalignment. So you can see here that if you lose joint space just on one side, you increase in the knee in particular, because it takes the whole body weight, you increase the load over that side of the joint. The remaining cartilage is vulnerable and can be damaged. This is where you can get some inflammation and the joint swelling. You get bone remodeling, and all of that leads to more local cartilage damage and worse malalignment. So it's a bit like a vicious cycle. So can we do anything about that? Well, there's a couple of things that have been trialed. Lateral heel wedges, which try to reduce the load off that narrowed side, and knee braces, which have been shown to be beneficial to some extent. Similarly, in hip osteoarthritis, using a cane can be beneficial. So in terms of pharmacological therapies, paracetamol is our first line. Pain relief is reasonable, although it's supposedly less toxic than anti-inflammatories, although there's been a recent systematic review which may challenge that to some extent. And then second-line therapy tends to be these anti-inflammatory drugs called NSAIDs or COXIBs. They do have recognized long-term adverse effects on cardiovascular disease, and that's across all of both classes, although there are certain drugs that are slightly better than others. And in particular, they cause problems with stomach irritation, which is what the patients tend to talk to you about. And they're equivalent in efficacy to paracetamol. Other analgesics tend to be opioid-based, and they come with their own set of problems, such as the misuse potentially and other sedating effects. Topical therapies, you can use hot and cold creams to relieve pain. You can also use topical anti-inflammatories, which are helpful in adjunctive therapy. In terms of injections, intra-articular steroids, so injecting steroids directly into the joint, does provide good pain relief. It's most often used in knees. The relief tends to only be temporary, and there are issues increasing in infection, worsening diabetes or heart disease. And a recent Cochrane review and a recent systematic review showed that for both hip and knee OA, the evidence for good effect is actually fairly poor in terms of clinical trials. You can inject something like hyaluronate, which is supposed to be a mimic of the synovial fluid. This is slightly better, but it's more expensive. There are nutraceuticals, which are expensive to buy and not available on prescription. The Cochrane reviews, again, are not particularly supportive of those treatments. There are some trials ongoing for different therapies. Vitamin D was found not to be beneficial. Bisphosphonates, which are medications we use in osteoporosis, had some benefit but didn't meet their primary endpoint. Surgery is the most commonly, most well-recognized treatment for osteoarthritis. Arthroscopy, which is keyhole surgery, just to clear out the knee joint of all that, the debris that you might see. There is good evidence to show there is no benefit over placebo for doing this procedure. Patients get offered it by the orthopedic surgeons, patients have it, but actually given the waxing and waning nature of osteoarthritis, they'd probably get better anyway. So it shouldn't really be used anymore, but it still is. Joint replacement, on the other hand, works. So in summary, osteoarthritis is common, it increases with age, non-pharmacological management is really important, and arthroscopy is not beneficial. Those would be my take-home messages. And just to let you know about our first case, he retired, he played more golf, lost weight, and felt better. So much better, he thought he was Usain Bolt. That's my dad. That's why I'm allowed to use it.
Okay, thanks Jenny for a great talk. If you've ever wanted to ask a question about osteoarthritis, now's your chance. So people watching remotely, you can do this via the hashtag Rheum101 or the email address rheum101@manchester.ac.uk. If you're in the room here in Manchester, please just put up your hand. Questions on osteoarthritis for Jenny, please.
Hi Jenny, that was brilliant, thank you. So which bit of the sort of stuff on the images was the bit that actually causes the pain? Is it the spiky bits? Is it the joint space narrowing?
I don't think we know, because there's always been this really poor correlation between what we traditionally use and the X-ray findings and what patient reports in terms of symptoms. I think it's really tricky to say that those bone bruises, the bone marrow lesions that you talk about on the MRI scans, those seem to correlate a little bit better with pain. So maybe that's what's driving the pain. But in terms of like the detailed kind of mechanisms of the pain receptors there, I'm not sure that we know.
Okay, any further questions here in Manchester or coming in remotely? I've got a question for you, Jenny. Could you just tell us about, very broadly, the current areas of active research in osteoarthritis at the minute? What are the kind of burning questions, do you think?
So I guess there's a lot of interest in trying to find new treatments. So the pharmacological studies on those drug studies on bisphosphonates were somewhat disappointing because some of the outcomes measured were they did actually find some quite positive findings, but then because they didn't meet their primary endpoints, decided not to proceed with them. There's a trial in a similar drug that's ongoing with a drug called denosumab. And then the biomechanic approach, so things like the braces and those are other areas of research. Although I'm slightly aware there are probably a couple of people in the room who knows a little bit better than me, so I'm slightly hesitant to go any further.
Okay, thanks. It might just be worth pointing out as well for those people that are watching remotely via YouTube, there might be a slight delay between what's happening here and you watching it. So if you do have a question as a talk is going on, please submit it straight away and then it'll be ready for us to ask when it's time for questions.
Hi, yes. Mine's kind of quite a vague question, really. I'm curious, you talked about how the fact that ultimately people might require surgery for their knee, for example. Mm. I know it will vary from person to person, but at what stage might knee surgery be preferable to other types of treatment?
So it's often a decision that's taken in collaboration with the patient and the surgeon, and I think function is probably the primary goal that we're interested in improving. So it would be an assessment of how much their osteoarthritis is impacting on them. Age does come into it in both directions. There's a reluctance to operate on people too young because joint replacement surgery needs to be done again. The replacement joints only last so long. Although there's actually some quite good outcomes with revision surgery these days as well. But then you don't want to leave it too late because there may have been too much loss of the surrounding tissue, so things like the quadriceps strength and those kind of things which would be important for rehabilitation after surgery. And also patients, as they get older, require more other diseases that may make them less good candidates for surgery. So it's a fine balance of looking at those things.
Thank you, that was a really good presentation as well.
Thanks.
Okay, thanks. One more question down the front here as well.
Hi Jenny, great talk. So rheumatoid arthritis is associated with quite a lot of psychological symptoms like depression and fatigue. I was wondering whether osteoarthritis has the same associations or whether it's strictly just the joints that get affected.
It's not always thought about in that context, but the pain that patients get with osteoarthritis will have a strong association with depression. I'm not aware of data that shows as clearly the associations that we see in rheumatoid, because it's not so much of a systemic disease. But the psychological impact of that loss of function that you get, and also the fact that it's so strongly associated with aging, I think there's that feel like my body's just falling apart. So this is not based on data, but more just like clinical experience that I'd say it definitely impacts on people's mood. But I can't quote papers at you, I'm afraid.
Thanks, Jenny. Thanks to Jenny and thanks to all our questioners. Could we just show our appreciation for Jenny taking the time to give her talk today? Okay, so we've got one more talk for you today, and that's on the subject of rheumatoid arthritis. We're very fortunate to have Professor Kimme Hyrich giving this talk for us. If it sounds like I'm stalling a bit for those watching online, that's because Kimme's just fitting her lapel mic at the minute.
Can you hear me?
Okay, over to you, Kimme.
Right. So Jenny talked to you about what we consider to be the prime example of a perhaps non-inflammatory arthritis, and now I'd like to talk to you about what is the most common inflammatory arthritis. So you've been sitting for half an hour now, so now we're going to do a little bit of calisthenics to get started. Raise your hand if you've heard of rheumatoid arthritis. Okay, this is a very promising start. For those at home, every hand is up. Oh, keep it up. Keep your hand up if your PhD studies or your research includes rheumatoid arthritis as its subject. So about half the room or so. Keep your hand up if you've actually met someone who has rheumatoid arthritis. Very good. Okay, so most of you have had the opportunity to meet someone with the disease that you're studying, so that's excellent. So rheumatoid arthritis is primarily a disease of something we call the synovial joints. And just to let you know what I mean by synovium, this is your knee joint. And you can recognize the long bone, your femur. It joins onto another long bone called your tibia. Within the joint, you have cartilage, which offers padding. You have menisci. And then you can see this tiny little red bit here. This is a single layer of cells called the synovium. And the synovium has a crucial role in providing nutrients and lubrication to the joint, because the cartilage in, itself does not really have a blood supply. So the synovium, that single lining, is really looking after your joint. Most of the joints in our body are synovial joints, which means that almost every joint in your body can be affected by rheumatoid arthritis. There's a few exceptions, and the main exception is your spine. So with the exception of the cervical spine, the rest of the joints down your spine are not synovial joints. And there's also the distal joints in your fingers. The very fingertips have very little synovium, so they tend to not be affected. Patients, when rheumatoid arthritis comes on, tend to experience joint pain and swelling, redness and warmth over the joints. They get a lot of joint stiffness, particularly in the morning, although increasingly as I speak to patients, the stiffness doesn't really go away if your arthritis is very active. It stays around all day. And they also will just feel generally unwell, fatigue, flu-like symptoms. So this is even though it's a disease of the joints, the patients are often systemically unwell. Rheumatoid arthritis itself is a worldwide disease. It's been found in all populations where it's been studied and all ethnicities. It tends to be more common in women with an average ratio of 3:1, although as you get older, that gender difference actually tends to disappear. The peak age of onset is often debated, but on average, it's in your 40s or your 50s. It can affect any age, though. I have patients in my clinics where they'll present for the first time in their late 80s or their 90s with rheumatoid arthritis, which is not fully understood. And there's even a type of juvenile arthritis, which is arthritis under the age of 16, that has a pattern and features almost identical to rheumatoid arthritis, and these are very young children. It's not uncommon, and it's estimated that among adult populations, 1 in every 100 people would fulfill the classification for rheumatoloid arthritis. So it keeps rheumatology clinics very busy. So this is a photograph of a hand of a patient that has rheumatoid arthritis. Now this is very subtle, but if you look closely at these joints across the knuckles here, which are called the MCP, and across the proximal interphalangeal joints, these are the first joints in your fingers, you can appreciate that they just look a little bit fuller than, say, your own. And those joints are swollen. You can see it here, perhaps a little bit more obvious in the joints here where they're quite swollen. Doesn't always affect the hand, as I said, although most photographs of rheumatoid arthritis tend to be the hands. And you can see here that this ankle joint looks very full, and this is indeed an ankle with swelling from rheumatoid arthritis. And again, here you can see very prominent swelling across these metacarpal phalangeal joints, what we commonly refer to as the knuckles. So rheumatoid arthritis, if left unabated, will continue to cause lots of swelling, and I'll show you a bit later on actual destruction of the joints. So the pictures I'm going to show you here are what are traditionally referred to as late-stage rheumatoid arthritis, where patients can develop a lot of deformities of the joint. You can get fixed flexion and extension of fingers, which are permanently deformed, and names that we've heard are called swan neck deformities. And if you can kind of imagine a finger that's cocked up like this, it looks like a head of a swan. So rheumatologists, we call it like we see it. And here's now some real photographs, and you can see this patient would not be able to straighten their fingers. So this is long-term, well-treated rheumatoid arthritis. Patients can get this very profound swelling in the MCP joints that often becomes resistant to treatment. Again, this is an example of something called ulnar deviation, where the fingers drift off to the sides. And again, it can be very destructive in the feet, making it very difficult to walk. So not only are the joints here no longer straightened, but you can imagine the joints themselves can slip out of their joints, and patients end up walking directly on their bones, and they can cause calluses. And you can get these deformities in large joints as well. That patient has what is unfortunately called windswept knees. So rheumatoid arthritis is an erosive arthritis. So as you're going through the Rheum 101 lectures, you'll come across some of the other conditions we treat, such as lupus, and you'll start to hear terms non-erosive arthritis, but rheumatoid arthritis is one of the classic erosive arthritis. And this is what I mean by that. So this here is the picture that you saw earlier with the single layer of synovial cells. The synovium is thought to be the main target in rheumatoid arthritis, and it becomes inflamed. The synovial tissue, which is usually a single layer, starts to proliferate. There becomes more synovial cells. The cells themselves become larger, and they can start to secrete destructive enzymes. At the same time, an inflammatory response is present. You recruit inflammatory cells into the joint fluid. And what happens is this synovial layer grows and grows and grows, in a way almost like a tumor. It can eat into the bone, it can eat into the cartilage, and at the same time is secreting enzymes that can start to erode and degrade away from that. And if you look at that same thing on an X-ray, you can see here this is a joint that's fairly normal, and as you progress, you can see here that the bone itself has been eaten away with a large erosion. And these are just a few more examples. This is a foot, and you can see here quite large, looks like someone's taken a bite out of the bone. This is a patient that's had quite long-standing arthritis, and you can see erosions, and you can also see that the joints are no longer aligned. So unfortunately, we do not know what causes rheumatoid arthritis. We know that it's an immune disease. We think that the CD4 T cell, which is one of your lymphocytes, is one of the main players, but we know that the immune response also does take on the same type of response you might see if you were exposed to an infection, as if there's been an antigen presentation. All of this cascades down, and the end result is the secretion of a lot of cytokines, which are proteins in the body, which they're like messengers, and they tell one cell basically telling someone else what to do. And they're saying, there is inflammation, we need to fight it off. There's been a lot of work, both in the rheumatology group in Manchester, as well as others, looking at what could cause this. And it's thought to be one of these complex genetic diseases where there's probably an environmental trigger of what we don't know in a genetically susceptible person. No, I'm not a geneticist, but we do know that there's a strong genetic risk factor for rheumatoid arthritis. The background risk in the population is 1%, We know that children will have a 3 times increased risk if their parents are infected. Twin studies have also found that there's an increased risk among monozygotic twins. And although we think that the strongest gene is your HLA-DRB gene, which is one of your immune-controlling genes, there's now over 100 different genes that in different people have been found to be associated with this. So it's even more confusing. We know that it's more common in women, but there's been lots of studies looking at exposure to hormones, hormone replacement therapy, and none of them have been conclusive to suggest that it's the hormones that are making the main difference. Interestingly, women that have rheumatoid arthritis and then become pregnant actually feel better. And it may be that during pregnancy, your immune system is somewhat suppressed because you're growing a foreign object inside of you, as our last speaker was experiencing. Unfortunately, though, in the first year after you give birth, it's one of the most common times for rheumatoid arthritis to start. So this is a terrible time when women are having to cope with young babies and then suddenly are also disabled by arthritis. There's been lots of work on risk factors as well. We know cigarette smoking is increases your risk. It's probably increased with obesity. Now at the bottom, there's some good and bad things. Red meat is probably bad, but the Mediterranean diet here, indicated by the olives, is probably good, whatever that means. And you'll be pleased to know that moderate alcohol has also been shown to be protective. So this is always good news when I'm speaking to medical students. There's also been a lot of interest in infection, and they have been globally negative in terms of Epstein-Barr virus, parvovirus, and others. So there's right now no convincing evidence, at least of an infection that we are aware of. So I mentioned at the beginning that rheumatoid arthritis is a disease of the joints, but in fact, many patients have inflammation and manifestations elsewhere. Some of you in your research will have heard of something called rheumatoid nodules. So this is a rheumatoid nodule. I think it's quite dark on this projection. But basically, this is where the elbow should be, and there's basically a ball under the skin. And they are nodules. They're firm but soft at the same time. They move around. The elbow is probably the most common area for them, but they also, and I'm starting to think maybe even more common on fingers. And a lot of patients, we actually have to send them to surgeons to get them cut off because they do start to interfere with holding a pen, holding their cutlery, etc. They're not painful, they're just annoying. Patients can also have inflammation in other areas of their bodies. So their salivary glands can become inflamed and they get very dry mouth, their tear ducts. Rarely, but seriously, patients can have inflammation called pericarditis, which is the bag that your heart sits in. Patients can get inflammation inside the lungs, so they can get fibrosis. I won't show you pictures, but patients can get inflammation in the cornea of their eyes. And rarely they can get inflammation in the blood vessels and the nerves as well. So although the number one symptom is the joint disease, it's often some of these other manifestations where the real disability and morbidity of the disease. So how do we diagnose rheumatoid arthritis? So it's a clinical diagnosis. There is no one test that any physician can do to say with certainty that this patient has rheumatoid arthritis. Some of you will have heard of the 1987 ACR, or American College of Rheumatology classification criteria. These aren't diagnostic criteria, but they're for use in research where a patient has symptoms for at least 6 weeks and they have at least 4 or 7 of these manifestations. The confidence is that this is a patient that has rheumatoid arthritis for research. One of the objections of this now quite dated classification is it does include things such as joint destruction, erosions, nodules, where you actually need disease for a long time to develop, because these don't develop on the first few weeks of you having it. And in fact, we now know, and I'll talk about treatment at the end, that early treatment is important, so we need to be able to classify people for research early on. So this is a new classification criteria that doesn't look at the damage of the disease, but it looks at the type of inflammation that you have. So which joints, do you have a positive antibody, which I'm going to talk about next? Do you have inflammation, and how long have you had it? So there are two common autoantibodies in rheumatoid arthritis. And an autoantibody is an antibody. Just to remind you, an antibody, we all have them. They're normal, they're good usually. They're what our body has to fight off primarily infection. It's why you get immunized as a child, so you can develop an immune response. In autoimmune diseases, the body is now becoming immune against itself. So we develop antibodies that we shouldn't, that are actually targeted against parts of our own body. And in rheumatoid arthritis, there's felt to be two of these. One is called rheumatoid factor, which we've known about for decades and decades, and more recently, something called ACPA, anti-citrulline protein antibody, and anti-CCP is the most common. So rheumatoid factor is an interesting antibody because we actually don't know what it's doing in rheumatoid arthritis, but a majority of patients will test positive for rheumatoid factor antibodies. So it's an antibody directed against other antibodies. What its role is, as I said, we don't know. 50% of patients will have this at the first presentation to a physician, and over time it's estimated up to 80% will have this. So as I said, we don't know what it does, but if you do have it, you tend to have more severe disease. What makes it challenging and why it's not a diagnostic test for rheumatoid arthritis is we actually see it in a lot of other conditions. And indeed, even patients that have chronic infections like hepatitis, certain cancers can also develop antibodies called rheumatoid arthritis. The new antibody, or newer now, is something called anti-CCP. And this is an antibody that is involved in part of the process of how we process something called amino acids, which make up proteins in our body. Again, like rheumatoid factor, there's little evidence for a direct role, but we know that unlike rheumatoid factor, you don't tend to see anti-CCP in other diseases, so it's a bit more specific. Patients can also have quite profound anemia. They can have higher levels of a drug, of a cell called platelets, and they tend to have an inflammation response. Two of the most common measures that you probably will have heard about if you're studying rheumatoid arthritis is the disease activity score and the HAQ score. So I wanted to briefly tell you what these are. The disease activity score is a composite measure of what is meant to represent disease activity in rheumatoid arthritis. And in concept, it's meant to be a capture of active inflammation. It's not something that you can calculate in your head, and most rheumatologists will use either a computer program or a calculator to calculate this in clinic, but it takes into account how many joints are sore, how many are swollen, how much the ESR is raised, as well as how the patient feels in themselves. And we score it from essentially 0 to 10, and any score above 5 is considered to be high disease activity. The problem with the DAS is there's been a lot of debate recently over whether a tender joint or a high global health score are actually representing inflammation. So therefore, there's been a lot of debate about whether this is the best score, but everyone that complains about that, none of us can think of anything currently better, so it sticks. The HAQ score is the other, probably most commonly used outcome measure, and unlike DAS, which is measuring disease activity, HAQ measures functional ability. And it's looking at how much the disease has affected someone's mobility. And the questions are very straightforward. It asks questions like how easy is it for you to get dressed? Can you get in and out of a bathtub? Can you get in and off a toilet, for example? And the score is between 0 and 3. 3 is the most disabled, and 0 is no disability at all. And just to give you an idea, if you just do the general population, where most people don't have a lot of disability, the average score will be 0.5. The average score in rheumatoid arthritis is about 1.2, and the most severe patients that are requiring biologic therapy will be around 2. Unfortunately, HAQ is not perfect either. Although it does correlate with disease activity, it also correlates with the erosions that patients have, which aren't reversible. We also know that it goes up with age. It seems to be higher in females, and there's probably a lot of other factors, such as other diseases the patients have that can also raise the score. So the impact of rheumatoid arthritis is great. There's been a number of studies to confirm that mortality is increased about 50% higher than the general population. We know that the number one killer among patients with rheumatoid arthritis is premature heart disease, but we also know that certain cancers, such as lymphoma and lung cancer, are increased. Depression is very common, and unfortunately many patients stop work early and are living with chronic pain. So finally, I'd like to talk about treatment. We've been trying to treat find antirheumatic therapies since the beginning of time, where it was now discovered that ingestion of willow bark is quite effective. I would not recommend it, but it is the same root component of aspirin. The first substantive treatment for rheumatoid arthritis was cortisone therapy, and indeed the development of cortisone back in 1949 won someone called Professor Hench the Nobel Prize for Medicine, and it was after showing the remarkable change that high-dose steroids can have for rheumatoid arthritis. And you should look up those videos on YouTube. However, we know that cortisone is associated with terrible side effects, and we tend to now avoid it in clinic, with the exception of intra-articular joint injections. The first mainstay of therapy, if you were to see a rheumatologist with your first diagnosis, is treatment with something called disease-modifying antirheumatic drugs, or DMARDs. And methotrexate, sulfasalazine, and antimalarials such as hydroxychloroquine now are primarily the three that are used. They're good drugs. They're good drugs if they're used early and at the right doses. They do all have side effects, such as the ability to make your liver enzymes read high, so patients do have to somewhat limit how much alcohol they use. They probably do increase your risk of infection, so patients are monitored with quite regular blood tests. Something like methotrexate is once a month. Biologic therapies differ from DMARDs. DMARDs are immunosuppressive therapies, but for many of them, we don't know how they work. Biologics are targeted therapies against some of the cells and the proteins that are actually involved in inflammation. And they've been a dramatic introduction into rheumatology now, the first one being licensed in the year 2000. And these have probably taken patients who, had they not responded to methotrexate, would have been left with severe disability, and now taken another large group of patients and put them into remission. They're antibodies in themselves, many of them, so they will then go into the body and they will attack the cytokines and the proteins that are too high, causing the inflammation and essentially removing it from the body. There are a lot of them. And some days it is hard, particularly with the anti-TNF drugs, to remember what they are all called. The thing to know is that they are effective. They're not better necessarily than methotrexate, but they're very effective when used appropriately. Their long-term safety remains unknown, like any new drug that's interfering with the way our body is responding to, in an immune situation, do need to be monitored. The main problem here is they're exceptionally expensive. Methotrexate will cost £200 a year. Etanercept, until recently, would cost £10,000 a year. So people are very interested every time I write a prescription for a biologic. So to summarize, rheumatoid arthritis is a disease of unknown etiology, primarily affecting the joints, but as I've seen, it can affect a number of tissues. Results in chronic pain, disability, and early mortality. It's a clinical diagnosis. And traditionally, therapy has been poorly tolerated, but I think with the new way that we use DMARDs more aggressively, as well as the introduction of biologics, hopefully a lot of the chronic, long-term destructive damages I showed you in photographs at the beginning will become less and less common.
Thanks, Kimme. Another great talk there, I'm sure you'll agree. Do we have any questions either in the room here in Manchester or people watching remotely via Twitter and email? Actually, we did have a question come in on the previous talk just a little bit after we'd finished the questions. Just to say again, there is a slight delay, perhaps of about a minute, between what's happening live in Manchester and people watching on YouTube. So if you're watching and you have a question, please get it in soon, and we'll come to you. Well, I'll start us off with a question, Kimme, and that's about, you said something like, the difference between classification and diagnosis. So for those of us who research involves rheumatoid arthritis, it's perhaps sometimes confusing to us, and if you, like myself, you're from a more mathematical background, the classification system is very easy to follow, whereas a diagnosis seems a bit subjective.
Correct.
Can you just explain the difference?
Well, you've probably heard the term medicine is an art. And I think for a lot of specialists, particularly specialists that are treating chronic diseases, there is an art to making a diagnosis of rheumatoid arthritis. If a patient presented in clinic with 10 swollen joints, I measured their rheumatoid factor, it's very high, their ESR is very high, I have no doubt that that patient has both classification of rheumatoid arthritis for a clinical study and they have a diagnosis of rheumatoid arthritis. Unfortunately, that's not often how patients present. They will present with some swollen joints. They may have a negative rheumatoid factor. They don't have any family history of this. They maybe only been unwell for 3 to 4 weeks. And it's that point where I have to make a decision in the clinic. Do I wait for them to fulfill the classification, or do I make a diagnosis now and start this patient on treatment? And usually you do the latter. So that's why it is important. Now, some of those patients where I make a quick decision to start them on a DMARD may not have rheumatoid arthritis, but as a physician, I don't have another test yet that I can do, so I will give them a diagnosis of rheumatoid arthritis. Whether that patient that presents slightly different than the person that has the quite classic picture of rheumatoid arthritis, whether they both do similarly in the long term or respond to therapies, that's where I think classification criteria come in and become important, so that you make sure you're researching a more homogeneous group of patients.
Thanks. Question up here.
Hi, Kimme, thanks. That was really helpful. My question perhaps relates to Jamie's, and you mentioned the original 1987 ACR classification, and it's been updated in 2010. I may have missed it, but is that also for research purposes, or is that a clinical set of guidelines as well?
Yes, so both of those. In fact, I didn't tell you about the original criteria from the 50s, which were even more vague and included definite, possible, and probable rheumatoid arthritis, which have been long discounted. So the new classification criteria are still meant to be classification. They were primarily developed for clinical trials. We know that in rheumatoid arthritis, the earlier you start treatment, the better the patient will fare, because the less and less inflammation they have over the long term, the less they are likely to develop the erosions and joint damage. The original the 87 classification criteria were actually developed among patients who had disease already for on average 7 or 8 years. So therefore, new classification were developed that you could start to apply to patients as they're presenting within the first month or so of disease.
Thanks. Sebastian, did you have a question?
Hi, Kimme, thank you for your talk. I had a question about disability. In RA, what are the biggest contributors to disability? Is it more the hand function or the activity, the reaching, the grip? In your experience, what is it?
So that's a really good question. So the HAQ score actually captures all of those. And I imagine that it will differ between patients. And because it's kind of, you may be familiar with the World Health Association terms about functional ability. The older ones were impairment and disability. They've been updated now with around participation. But for something to functionally impair you, it has to impair something that you're doing. So I have patients that are manual laborers, and suddenly holding a saw or a hammer is very difficult, and often people that are in those types of jobs are more likely to leave them early as opposed to someone with an office job where they don't have to be on their feet. And most patients with rheumatoid arthritis do have hand disease, but a lot of people, it will be the mobility that disables them, so they need a wheelchair or something like that.
Okay, perhaps one final question from me then, Kimme. You talked about biologic drugs, and anyone at all familiar with RA will know about the revolution in treatment and outcomes for patients that came about with biologic drugs. What's next in RA?
So, biologic drugs are big business. We will continue to see more and more biologic drugs because they are effective. And so the what next will still be continuation of what we have. There is also, as we learn more and more about the way that rheumatoid arthritis affects our immune system, we realize that there may be other parts of the way our immune system works that may be better to block. So there are new drugs. So one of the drugs I've not talked about are something that blocks a JAK pathway, and these are actually oral. All of the biologics we have are injections. There's actually some oral drugs coming out. The big direction, though, is I've showed you that long list where we have now 13 biologic agents. I have no idea which one to choose. So a patient could come to me, and it may be that a drug that blocks interleukin-6 cytokine is the best drug for that patient, but I've been using anti-TNF drugs for 15 years, and that's just my habit now to use that. So a lot of the work, I think, now will go towards trying to get a greater understanding of the biologic variability between patients to understand why this patient responds to this drug, this patient responds to that drug, but perhaps at an earlier stage.
Great, thanks, Kimme. So I'd just like to finish with a plea to people to give us feedback. I'll do my very best to make sure nobody can leave this room without filling in a feedback form. But anyone watching online, please visit our online survey, the URL of which should be displayed on the slide for you now. This is a pilot, so we'd like to know how we did and how we could do better in the future. And also, I'd just like to thank Holly and Katie and Stevie for help with running the event today, and for Jenny for help with organising it as well. And to finish, can we just thank both our speakers once more for today? Thank you.